Welcome back guys. Now in this video, let's discuss about the types of vegetations. Already where we have discussed about the vegetations in rheumatic heart disease, we have discussed about the vegetations. In infective endocarditis also we have discussed about the vegetations. In which other conditions the patient can have vegetations in the heart? Same. Now I want you to know, especially for your exam purpose, in rheumatic heart disease, yes, vegetations are present. I hope you can see the vegetations. In infective endocarditis also see the vegetations are present. And there is a condition called as NBTE, non-bacterial thrombotic endocarditis. In non-bacterial thrombotic endocarditis also you are going to have the vegetations, no doubt. And in a condition called as Libman-Sacks endocarditis, okay, Libman-Sacks endocarditis, even you are going to have the vegetations. Vegetations are present. So now how these vegetations are differ from one another? Okay, let me start with the rheumatic heart disease. See, in rheumatic heart disease, first point number 1. See, the vegetations, are they sterile vegetations or are they septic vegetation? They are sterile vegetations. Okay, they are sterile vegetations, which means they do not have any bacteria, and it is not because of a bacteria. The vegetation is not because of the bacteria, it is because of the autoimmune damage. Okay, rheumatic heart disease is an example of type 2 hypersensitivity reaction. It's the autoantibodies which are damaging the heart. Okay, so sterile vegetations. And where exactly these vegetations are present? The vegetations, the keyword what they will use in your exam is vegetations present along line of closure. So along the line of closure, the vegetations are present, and the vegetations, they do not cause any damage to the wall. Okay, they are non-destructive. Okay, they are non-destructive. They are the sterile vegetations. And what is the chance of embolization? See, these vegetations, they are firm. Usually they do not undergo embolization. Do not embolize. Okay, they do not undergo embolization, which means they do not dislodge from there and they do not cause the embolization. Why? Because they are firm. Okay, so there is no risk of arterial embolization. So these are some important points about the vegetations in the rheumatic fever. Now what about the vegetations in infective endocarditis? Let me write here, infective endocarditis. See, the first point number 1. What about the vegetations? The vegetations are sterile or the septic? They are septic. Okay, they are the septic vegetations, which means they contain trillions and trillions of bacteria. Okay, and next important point is vegetations where they are present. They are present both above the wall as well as below the wall, but mainly the most common site of the vegetations is upper side of the wall. Okay, most common site. See, remember, the vegetations are going to be present both above as well as below, but the most common site is upper side of the wall. The vegetations are going to be seen on the upper surface of the walls. That one point I want you to know. And these vegetations, they are septic vegetation, they are present on the upper surface of the wall, but in rheumatic disease, the vegetations are present along the line of closure. Okay. Next, these vegetations, they will destroy, damage. They will damage valve. They will damage the valve functioning, and they can lead to regurgitation and murmur. They are the one which will damage the valve, and high risk of what? Embolization. There is a high risk of embolization. Why? Because these vegetations, they are destructive. Yes, they are destructive. They will cause the damage to the wall, and they are not going to be firm. They are very much friable. They will detach from there and they will go to different parts of the body. That's what we have discussed under the minor criteria, the vascular phenomena, the septic emboli in the topic of infective endocarditis. They will detach from there and they are going to spread through the different parts of the body. If this microemboli, if these vegetations, if they get larger in the cerebral vasculature, they will lead to hemiplegias. Because of this septic emboli, there is a dissemination of the bacteria throughout the body which will lead to the splenomegaly. There will be massive splenomegaly even while doing the palpation, you can actually feel the tip of the spleen. So that much massive splenomegaly is going to be seen. Okay. So some important points about the infective endocarditis. Yes, they are septic vegetations. True. They are most destructive. They will cause the damage to the wall. They are present in the upper surface of the wall, and there is high risk of embolization. Done. After this, some new things which you don't know are non-bacterial, okay, NB, non-bacterial, thrombotic, endocarditis. Okay, non-bacterial thrombotic endocarditis, which means in the name itself it is there, non-bacterial, bacteria is not involved. If the bacteria is not involved, so vegetations are going to be sterile or septic? Sterile. Okay, sterile vegetations, no doubt. And in the name itself it is there, see, because of some reasons thrombosis is happening, clots are forming in the heart, and endocarditis is there, inflammation of the heart along with some clots in the heart, some small vegetations, clots which are forming in the heart. Why is this happening? See, this is because of hypercoagulable states. Hypercoagulable states. See, the patient is having some hypercoagulable state. Now, what might be the reason? This hypercoagulable state might be because of some cancers like AML, acute myelogenous leukemia type 3, M3. Now, if the patient is having this acute myelogenous leukemia, patient will suffer with hypercoagulable state or certain types of cancers and the conditions where the estrogen levels are elevated. We all know estrogens, they are responsible for increasing the clotting factors. Estrogens will actually cause the deep venous thrombosis. Okay, thromboembolism. Estrogen, high amount of estrogen can cause a thromboembolism. So the point which I want to put into your mind is, see, there is some underlying cause, like some cancer or some something is there which is leading to hypercoagulable state, and because of this hypercoagulable state, some small clots are forming within the endocardium, and these clots, they are absolutely sterile. Okay, they are absolutely sterile, and where they are present, these vegetations, important point, they are present along the lines of closure. Just like rheumatic heart disease, even in non-bacterial thrombotic endocarditis, the walls are present. Okay, sir, the vegetations are present along the walls of closure. So, will they undergo embolization? Yes, they will also prone to embolization. Prone to embolization. Even they will detach and they will cause the embolization. So, non-bacterial thrombotic endocarditis is completed. Remember, non-bacterial thrombotic endocarditis is because of the hypercoagulable state, because of some cancers like acute myelogenous leukemia, M3, okay, M3 variant. And the last one which we are left with is Libman-Sacks endocarditis. See, this Libman-Sacks endocarditis, okay, I remember the word L and S, E. See, just try to rearrange the words. L, S, E, just like S, L, E. So, this Libman-Sacks endocarditis, it is seen or it is associated with S, L, E, association. Which means it is associated with the systemic lupus erythematosus. So, it is what kind of disorder? It is autoimmune. It is an autoimmune condition. If it is an autoimmune condition, it is an autoimmune damage to the endocardium. It's autoimmune damage to the endocardium. So definitely whatever the vegetations which are occurring due to the damage, they are going to be sterile or they are going to be septic. They are sterile. Because of the autoimmunity, right? It's not because of some bacteria. The autoantibodies which are seen in the systemic lupus erythematosus, now they are attacking the heart, endocardium. So they are absolutely again sterile. Okay. So SL, L, remember the word L. L stands for where? Lower. So both the vegetations are going to be seen on the upper surface of the wall as well as the lower surface of the wall, but mainly they are seen on the lower surface of the wall. Lower surface. Okay, lower surface or the lower side of the walls. They are seen on the lower side of the walls. Now, are they prone to embolization? Now the question is, are they prone to embolization? Not much. Okay, not prone to embolization. They are not prone to embolization. So with this we have discussed different types of vegetations. So the 4 types of vegetations which I have discussed here are the vegetation seen in the rheumatic heart disease, the vegetation seen in the infective endocarditis, the vegetation seen in the, non-bacterial thrombotic endocarditis and Libman-Sacks endocarditis. Out of all these 4, in 3 conditions the vegetations are going to be sterile. The only condition where you will see the septic vegetations are infective endocarditis and they will damage the walls. Okay, so destructive vegetations are seen in infective endocarditis. More prone to embolization are seen in infective endocarditis as well as non-bacterial thrombotic endocarditis. Okay, in non-bacterial thrombotic endocarditis also they are very much small, they are very much friable, and they are also even prone to embolization. So with this, the comparison of different types of vegetations and different types of conditions is completed. Hope the video is helpful. Thank you.